So I'll be talking about why targeted metabolomics is essential for population health, but I think this is also it's sort of a talk about the need for quantitation in all fields, all omics fields, and I think we've heard a lot about the different omics approaches to precision health and to population health. So I think, am I allowed to press the next slide or? Okay. So now we've got the cover slide and I'll dive right in. So as Rachel mentioned, I've been involved in developing and maintaining this database called the Human Metabolome Database for more than 16 years now. And it's given me, I think, a really useful perspective on how the field has evolved in metabolomics, but also a broader perspective, because I've been in this game for a long time, to see how other omics fields have also evolved. It is and was designed to be a resource for human health and for population health, to help with the characterization and translation of metabolite markers to understand disease and disease processes. The database has grown from just a couple thousand metabolites 15 years ago to more than 250,000 metabolites with hundreds of thousands of pathways and millions of reference spectra, but also a lot of information about diseases and metabolite concentrations associated with those. So as I said, it was designed to be a reference resource for both human disease and medical applications in population health. As part of this database, we've been building or gathering data from both targeted metabolomic studies and untargeted metabolomic studies. And Gary highlighted some of the applications of untargeted metabolomics. As I said, this database, because we've been updating it for 16 years, has allowed us to see some long-term trends and what's being accumulated, what's being measured, why it's being measured, and trends in terms of both technology and preferences among scientists. So just to dive in a little bit, for those who aren't too familiar with metabolomics, there are two routes that we talk about. One is a targeted approach, the other is the untargeted approach. Untargeted approach uses high-resolution mass spectrometers, things like Orbitraps. It will do a lot of data processing, looking at large collections of spectra, spectral alignments, spectral adjustments, peak picking. It then will follow through a variety of multivariate statistical techniques to identify relevant or important peaks, and then from those important peaks, you'll produce a list of changed or altered metabolites. Targeted metabolomics is a little different. Typically, you don't use high-resolution mass specs. You'll use tandem mass specs, often triple quads. You may use multiple plates. You'll often work with things like kits. Many people are familiar with biocrates kits that allow you to identify a preset, a collection of metabolites. You'll have standards, and using the software that comes bundled with these systems or developed in-house allows you to identify and quantify a preset collection of metabolites. Now, you can also do targeted and untargeted proteomics, and we saw in the earlier presentation about the Pharmaceutical Proteomics Initiative, where you can use things like untargeted mass spectrometry to do proteomics, or you can use things like Luminex or Olink or SomaLogics to do targeted proteomics. Each of them has their strengths and weaknesses. In terms of targeted metabolomics, typically it's limited in that there's generally a limited coverage of pre-selected molecules. It's primarily intended for hypothesis testing, so it's not ideal for discovery, or at least that's the perception in the field. But there are real strengths in targeted metabolomics. It focuses on absolute quantification. It's amenable to automation. It can be very fast, and it can be developed or produced in terms of kits. It's fairly highly standardized, very reproducible, and standardizable. Now, the untargeted approaches, that Gary highlighted some of those, allow you to get very broad chemical or metabolite coverage, tens of thousands of features. As Gary highlighted as well, there's a huge potential for discovery. It's ideal for fields like exposomics. And in that regard, it's useful for hypothesis generating. But untargeted methods are not quantitative, hardly at all, actually. And generally, they're not very fast, and automation is not generally very feasible. They're not well standardized. In fact, every different lab uses a different method, and this has been a real problem. in the field. So I've been looking at the trends. As I said, I've been working in the field of metabolomics for a long time. And I'm looking at the number of metabolomics papers that were published. Not only I've looked in PubMed, I've looked in Google Scholar. So we're looking at these graphs between 2011, 10 years ago, and 2021, which is the last year we have complete data. And I was looking essentially for a number of papers and then the percentage therefore of untargeted studies versus targeted studies versus quantitative metabolomic studies. So back in 2011, the number of untargeted metabolomics studies was a minority. The vast majority of published studies, 3/4 of them were actually targeted studies. And about 16% were stated as quantitative. It's probably higher than that, but it was a decent portion. So what's happened over the last 10 years? So something rather dramatic. So now the percentage of untargeted metabolomics papers represents 2/3 of all published papers, and the targeted metabolomics papers represent just 1/3. And the percentage of quantitation has fallen from 16% down to 7%. Now you can run this through the same analysis with PubMed abstracts, and you get very similar numbers. Quantitations may be a little underestimated. So why has there been this dramatic shift towards untargeted metabolomics? A lot of it comes from an appeal to this idea of discovering a new compound or a novel biomarker. And based on the data we've seen over the 15, 16 years of running metabolomics with HMDB, we only see about 1 to 2 new compounds identified for every 10,000 published metabolomic studies. So the odds that you're going to find something new is very small. There's also, I think, a general belief that more compounds can be identified by untargeted metabolomics than targeted metabolomics. This is something that's changed quite dramatically over the last few years. This was true, but it's changed quite dramatically. So there are now systems that are out there, whether it's the biocrates systems and the new Excel kit, where I think it's up to like 1,200 compounds. Metabolon has a targeted approach, generally around about 12 to 1,400 compounds that are identified. And in many cases, these can also be quantified. On average, if you look at the untargeted papers and evaluate what they've described and published, most targeted studies get fewer than 100 compounds. There are some labs that can go more than that, but the rule is it's typically less than 100. There's also the presumption that untargeted metabolomics is generally faster and easier than targeted metabolomics. And our own experience and discussions with many other people that have tried using targeted versus untargeted, as a rule, untargeted methods are about 5 to 50 times slower than targeted methods. Some labs can do it faster, but the majority of people find that this is how long it takes to analyze their data. And so that also affects the presumption of how cheap things are. So most people went to untargeted because they felt it was cheaper to run. And in some cases you can do it, but you produce relatively useless data. Typically targeted assays can be run for as little as $35 a sample. Untargeted assays, because of the costs for high informatics and data processing, typically run a lab or commercial facilities about $200 per sample. And one of the drivers, and I'm just as guilty as anyone else, for moving to untargeted metabolomics is it's fun to write software for it because it's so hard. So I've been involved in creating resources for it, and many people in the field of metabolomics have created resources for untargeted metabolomics. It's great for innovation, but the result is that the field of untargeted metabolomics is not well standardized, and reproducibility is quite poor. The other thing that people believe is that if you can find novel markers, which you generally can't, you can then therefore patent them, and therefore marker discovery is better through untargeted. And what people don't realize often is that you can't patent natural products. You can't patent genes. You can't patent existing compounds. So most biomarkers that are approved or used or even patented are basically those that are assessed by concentration differences. So underline the word concentration. So the FDA requires precise quantitative measurements for approved biomarkers. That's important to remember. Now, I also want to revisit these slides here where I'll circle again this idea of quantitation. So there's targeted metabolomics, but not every targeted assay is quantifiable. And quantitation is essential, I think, if people want to move the field forward. But the trend we're seeing is just the opposite. We're doing less quantitation overall as a community. We seem to forget the fundamental definition of analytical chemistry. It is a branch of chemistry that deals with the quantitative determination of chemical components of substances and mixtures. This is why we measure things in moles and molar units. It's why we measure pH and absorbance. Everything that we've been doing for more than a century in analytical chemistry is about quantitation and getting things that are numbered and standardized. This is what metabolomics was supposed to be. So why have we shifted away from quantification? One, I guess we've forgotten the definition of it. Two, I think we have been influenced by what I'll call proteomics influencers or proteomics refugees. So in the field of mass spec-based proteomics, the workflows were largely adapted from those fields into metabolomics. And you can find many people who previously worked in proteomics labs have simply adopted the same software, the same concepts, the same tools to apply to metabolomics. The other thing that has, I think, concerning is that many people, and you'll see this in diagrams even today and most papers, when people show medical biomarkers, they'll usually show up arrows and down arrows so that biomarkers can be qualitative. And that's just plain wrong. Biomarkers, to be approved to be used in health applications, have to be quantitative. Now, for science and for publishing papers, you can show directions, but that's not leading to translation. And the topic for today and the focus, I think, for metabolomics, if it wants to survive, has to be about translating its discoveries into the clinic. The issue of quantification is something that was identified as far back as 2014 with this cover on trends in biotechnology and a cover notification that a specter or a ghost is haunting metabolomics, the specter of quantification. And even though that's now 8 years old, it's still an issue where the field has to be more quantitative if things are going to be translated to practical applications in human health, population health, and biomedicine and precision health. The advantages of quantification are obvious. Quantification makes things reproducible. It makes things verifiable. A value, a number, micromolar or mgs per mil, is a universal unit. We all understand it. Those units don't change over time. We haven't changed the definition of a mole for 100 years. It allows us to do direct comparisons of standardized healthy values. So HMDB has hundreds, thousands of these reference values that have been measured in the literature. They're in textbooks and elsewhere. You don't need to have a cohort of, quote, healthy controls. You just look those things up. So this is the advantage of quantification. It also reduces the cost of doing your studies. If we look at the markers that are used in medicine today, at least with metabolite markers, we can see that most of them are quantified, whether it's a glucose value and the threshold to decide on diabetes, the threshold for kidney damage for creatinine, or for cholesterol, or for uric acid, or for the T4 hormones, or the phenylalanine and tyrosine ratio. All of these are quantified markers. All of them have to be in order to be used as medically approved markers for health. And we've been using quantitative metabolomics in my lab for many years, and you can actually use it to get very good biomarkers and to get very good performance. It doesn't necessarily mean you've discovered a brand new marker, but you've discovered new concentrations and changes that are relevant. And these can be put into very useful equations, and algorithms can be translated directly to medical applications. So these are just some applications of using quantitative kits, quantitative systems to look at things like preeclampsia, congenital heart disease, cachexia, trisomy 21. These are all conditions. Some are prenatal, some are in adults, some are in pregnant women. The performance in terms of the ROC curves are all excellent, much better than what we get with other types of markers. Usually representing a panel of 2, 3, or 4 metabolites and their concentration changes. So you can not only predict diseases, you can also diagnose diseases using panels of metabolites and their concentrations. And most of these can be generated as logistic regression curves or equations, which are easy to use and easy to plug in. Some of these have actually been translated to the clinic. It was because of our adventures in working on metabolite biomarkers that we decided to look at biomarkers in general, to look at both metabolite markers, protein markers, genetic markers, karyotypic markers. And we created a database called MarkerDB. So it's been around for a couple of years. We've been able to track almost 1,100 different metabolite biomarkers. A lot of them have very detailed information about their ROC curves and sensitivity and specificity. We're able to identify about 140 protein disease markers. There's a huge number, about 26,000 genetic or DNA markers we've compiled. And almost all of these biomarkers that are in the database are quantitative. Something that we learned, but I think that's a message I want to pass on here. Quantitation counts when it comes to biomarkers. Now, I'm from Canada, and so I could get data about Canadian biomarkers that are approved. In terms of clinical chemistry, approved markers in Canada, there's just under 200. We can call those metabolomic markers. In terms of the number of approved genetic tests, even though there's like 26,000, most of them are in California, there's about 110 that are standardly performed in Canada and the rest of the world. If you look at the protein tests, most of them that are approved are ELISA-based. So those are antibodies, so there's about 60. In terms of the number of approved transcriptomics markers, there's 5. And in terms of the number of tests approved using mass spec proteomics, it's 0. So why is the difference between, say, metabolomics versus proteomics or genomics versus transcriptomics? Why is clinical chemistry so successful? Well, it's quantitative. If you've ever worked in a clinical chemistry lab, if you've ever had some clinical chemistry measured on a urine or blood sample, you'll get things like mgs per mil or micromolar or millimolar. Why is genomics so successful? It's also quantitative. That's because you get exact positions of the mutation. It's a length measurement. It's a change at base 7,726. And there's no difference, or it's not 7725 or 7724. It's precise, it's exact. So why is transcriptomics so unsuccessful? Whether it's microarrays or RNA-seq, it's not a quantitative measure. Same with proteomics, at least with mass spec proteomics. Most of the methods are not quantitative. So if we look at the mass spec-based proteomics, and I want to distinguish that from things like Olink or Luminex that were highlighted earlier. But in terms of mass spec proteomics, it's been around for about 30 years. It's been very heavily supported by the NIH. Almost $3 billion has been invested into it. And the major focus in mass spec proteomics was on peptide identification, feature identification. This was developed before the genome was sequenced. We wanted to figure out what was in the human proteome. The result was there was almost no interest in trying to quantify, but more to stamp collect, to catalog all the peptides you could possibly see. So the net result was, because there was so much focus on identification, but not on quantification, there are very few clinical protein markers that are used or come from proteomics, and not a single protein marker is clinically approved as an MS-based assay. We can also see some trends in terms of MS-based proteomics. So it was growing exponentially, very much like where metabolomics is now. And it continued growing, and then about 2011 or 2012, the growth slowed. And for the last 7 or 8 years, it's been quite flat. Now, in terms of the quantitative proteomics or targeted proteomics, that's growing exponentially now. So the question is, which way is metabolomics going to go? Is it going to plateau out, or is it going to continue to grow? So there are some lessons about mass spec-based proteomics. Ignore quantification at your own peril. Translating MS-based proteomics concepts and practices, the workflows that many people have adopted, is not really a good idea for mass-based metabolomics, because it ignores the ability to quantify. The winners, like genomics and potentially clinical chemistry / metabolomics, quantitative metabolomics, are those that offer techniques that are cheap, that are fast, reliably quantitative, and reproducible. And so I think metabolomics really needs to learn from the difficulties that mass spec-based proteomics has experienced. So there are two paths. One that leads to rainbows and ponies and unicorns, or another one that potentially leads to the Grim Reaper. So the question for us is, which of the two routes for metabolomics should we choose? What would you choose? So with that, I'll wrap up and thank you for listening.